Good afternoon, everyone. My name is Hirotomo Sato from Japan. It's my great honor to present my case here, and I'd like to share my case here. Thank you. My case was 87-year-old female. She was referred to our hospital because of worsening dyspnea. She had a surgical history of CABG 14 years ago before admission. The chest X-rays showed congestion, and the ECG shows LVH. TTE shows decreased EF. LVEF was 35%, and there was moderate AR and moderate MR. And AVA was 0.45. We diagnosed her as CVI. Her clinical Frailty scale was 4. After admission, we treated her with conventional medical therapy. Because STS score was 12, so high, our heart team considered that she was candidate for TAVI. So we performed CT. The aneurysm area was 499. That was right size for Sapiens 3, 26 millimeter valve. The Valsalva-LVOT was 27, 27, and 30. This is a deviation of classification, ST junction to LVOT. There's a few classifications in STJ. Valsalva, moderately calcified. And there is no classification in LVOT. There is no severe bending in aorta, and there is no significant stenosis in iliofemoral arteries. We check coronary angiography. Her RCA was small, and there was no significant stenosis in coronary arteries. 14 years ago, she was performed CABG because of left main stenosis, but there's no left main stenosis at that time. And bypass graft was patent. So this is my procedure plan. The area was 499. It was right size for Sapiens 3, 26 millimeter with nominal volume, but the valve was moderately calcified. So I decided 1 cc less than volume. So general anesthesia and TE guided TAVI was performed. This is AOG before TAVI. We checked perpendicular view, and BAB was done, 23 millimeter. And then we implant valve, 26 millimeter Sapiens 3 valve with 1 cc less than nominal volume. Carefully, slowly inflated. This slide shows TEE before TAVI. There was no abnormal findings. But just after TAVI, there was echo-free space near LCC. But it was located only limitedly only in LCC. Blood pressure recovered and hemodynamics was stable. LV wall motion was getting better rather than preoperative status. There was no evidence of ascending aortic dissection or cardiac tamponade by TEE. Fortunately, she had CABG before. There were few risks for cardiac tamponade because of adhesion. In addition, fortunately, RCA was small. If hematoma press LMCA, bypass graft flow will be helpful, we thought. After we reversed the heparinization, we checked the hematoma again. The size of hematoma did not change, and PBL was none, and we finished procedure. Once again, I didn't notice the findings. There was small calcification in LCC, but it's small, but it's the shape of the calcification is like a needle. The calcification did not move in BAB, but during the valve implantation, the calcification moved outside. Now, like that. This is CT after TAVI. There was limited located hematoma, like that. And the findings disappeared in 28 days after TAVI. In addition, I want to say this is TTE just after TAVI. We can see here in RCC. So we cannot find the LCC hematoma in TTE. There was only few pericardial effusion. This is TTE at discharge. LVEF increased to 55%, and AR was none, mild MR. LVOT calcification and aggressive annular area oversizing are associated with increased risk of aortic root rupture during TAVI with balloon expandable processes. Annulus rupture occurred in 1% from the Japanese registry. Most of annulus rupture cases were caused by using the Sapien XT valve. The shape of calcification in fluorography might be important to predict annulus rupture. TEE was helpful to diagnose this annulus rupture. Thank you for your attention.
Dr. Sato, very interesting. Lucky also.
Lucky. I was lucky.
Obviously, knowing what you know now, would you have changed anything in the way you did that case?
Oh, yeah. If I notice the findings, we should change the procedure. Valve change, self-expandable balloon.
Good idea.